When the pandemic first started, I remember being very concerned about what was going to happen to our hospital because Philadelphia is only 90 miles from New York City. At that time, New York was the epicenter of the pandemic. I'm a practicing emergency medicine physician and have been working on the front lines during the pandemic. So on this project, I've had this opportunity to interview frontline healthcare workers and also leaders at academic institutions all throughout the country.
That very first patient showed up on a Thursday, and quickly by Saturday, we understood that we were going to be overwhelmed.
Some of the biggest challenges I faced taking care of COVID patients at the time was really this huge sense of isolation. At certain patients' end of their lives, we were literally the only people that were there.
It was the realization that, yeah, this is something we've never dealt with before, and having to reshape, how small communities are going to practice healthcare.
It's been a great time for me to pause, reflect upon what we've been experiencing during the pandemic, and to think about how we've been innovating and being able to rise up to the challenge of taking care of patients during the pandemic. We got our first case of COVID on the same day in the state of Washington as South Korea recorded their first case. I had this opportunity to speak to Dr. Delitt from the state of Washington, and his hospital saw the first cases of COVID in this country.
We first had a case diagnosed in Washington state back in January of 2020. Because we saw the first cases, people looked to us and were really trying to learn from our experience. One of the things that we did early on is any of our protocols, procedures, policies, we made publicly available.
When COVID first hit the US, we had to creatively respond to the pandemic because there were severe constraints. There were supply chain issues of not having enough PPE. So, how do we come up with new protocols to protect our patients, protect our staff? And that required a lot of creativity to be able to innovate in real time. I actually got to interview healthcare system leaders all over the country, like Dr. Rheuban from Virginia, Dr. William Bornstein from Georgia, and Dennis Murphy from Indiana.
Well, I'm very proud of my colleagues at the UVA Health system. We expanded telemedicine to serve as virtual PPE and protect our providers and, of course, our patients as well. In fact, we wired more than 100 rooms, including our new bed tower, our emergency department, and many of our clinics to facilitate that model of care.
I'm incredibly proud of what our folks accomplished. It's just unbelievable. So we were able to, really run critical care as an organization rather than as individual hospitals.
We quickly set up a screening process and said, we're going to have to do this telephonically. We're going to have some sort of telemedicine process to handle all these patients. We were up and running with a full-blown screening function and pushing that out to all the local news media to begin to do that function. And not just for our own facilities, I think had learned pretty quickly from New York and Seattle how important it was to support nursing homes. And so beginning that outreach to all the nursing homes in our state.
I had a chance to speak to Dr. Janis Orlowski and her role at the AAMC and what the AAMC did to support academic medical centers during the pandemic.
We brought people together to share best practices. And so we would have phone calls with Dr. Fauci, we had phone calls with the CDC, we had phone calls with FDA, and we basically were running and learning at the same time.
as health changes, as medicine changes, as new pandemics or new threats come out, academic medicine is what responds. New curriculum was developed. Going from lecture to virtual was important. The educators did what they always did. They just did it at warp speed and with a warp energy. And that is, they created things with creativity, with energy, with compassion, and really trying to be student-centered. What was amazing and continues to be amazing, and actually wasn't surprising because it's what our medical students do, is how much they stepped up. Students did that. I think schools really benefited because they realized how much that student voice, truly being part of the table at the table made a difference. And then the most extraordinary things the students did, and there's countless examples at nearly every school, is they identified ways for them to help.
One thing that stuck out to me doing the interviews was the optimism of our young trainees.
I think, in terms of how we do things, it's just very different, obviously. COVID is kind of, in the backdrop of everything that you do, even in spaces that you wouldn't necessarily think about COVID. I'm a psychiatry resident, and in my first year, I do some internal medicine, some neurology, and obviously some psychiatry. And I got to do rotations in all three of those specialties, and seeing how COVID has played a role in that.
Everyone says that medicine is changing all of the time, but it literally feels like every 2 seconds there's a new update, something new to learn, some new policy change. And so I think it's really forced us to become a lot more adaptable. Although you're always trying to adapt, but I think this is really focused on how important of a skill adaptability is for an intern and really anyone in medicine.
In my interview with Dr. Ross McKinney, he emphasized the importance of researchers at academic medical centers, because researchers 10 years before the pandemic were already working on mRNA vaccines. And if they weren't doing that, we would not have the COVID vaccine this rapidly. Honestly, when we first started talking about vaccines, I thought it was going to be years before patients and healthcare workers got vaccines. I was amazed that we were able to get vaccines to the public within a year.
Two researchers behind technology used in Moderna and Pfizer vaccines have won what's known as America's Nobel, and they're from the University of Pennsylvania.
You had two big themes here going. One was the introduction of mRNA as a means to introduce genetic materials and to synthesize proteins in a person. That research was begun University of Wisconsin in the 1990s, or at least the first examples where mRNA was used to transfer genes into somebody to produce proteins. So you had the overall technology, you had the specifics, and you also had people working on coronaviruses and doing coronavirus research. So when the story of coronaviruses began to unfold, those institutions were ready. We were able to, we as the world of science was able to put together vaccines that incorporated critical parts of the spike protein, because we knew that, for example, spike protein was what defined how coronaviruses cause their disease, and that we knew what the receptor binding domain looked like. We knew what the N-terminal domain of the spike protein looked like. So we were ready and then could put together efficiently. And that a lot of that work was done in collaboration with the NIH, and then with startup company Moderna, or with Pfizer and BioNTech, where they put together these incredibly efficient and effective vaccines quite quickly.
It's so important for medical centers to have a relationship with the community that they are working in, because the core of medicine is a relationship that a provider has with their patient, and that relationship is built on trust. In my interviews with Dr. Sutton, Bonner, and Alberti, they emphasize the importance of building trust with the community.
So a lot of the beginning work was having conversations and awareness raising, and then transitioning more into the testing And also now we're having more and more conversations about vaccines and vaccine uptake. So part of the conversation is really making sure that any information sharing, anything that we're sharing with the public is grounded in community wisdom and input. Making sure that the language that we use is accessible, and also thinking about the people that are the messengers that we're using. Those are the key steps. The messengers should be trusted messengers. It should be people from the community.
Some of the work that AAMC has done at talking about getting trusted voices in front of the community has been important. I think there's a lot of my community that trusts my voice.
And it comes back to fundamentals, right? So for me, health equity is about opportunity. It's not about outcomes. It's not about ensuring that every community has the same endpoint. It's really about thinking about how we make sure that every community is at the same starting line for health.
We were really active with getting out in the community and having testing available for people where they are, not having to have the inconvenience of driving to a bigger city to get testing. We partnered really early with churches, especially churches in the Black community, for testing. And so it was easier to transition that to vaccines with the same churches and communities when it was time to be able to get those.
In my interview with Dr. Skorton, who is the president and CEO of the AAMC, he talked about the resiliency of academic medical centers and where we need to go in the future.
Think about the resilience. I worry a lot about the personal resilience of those in our profession, worry about their mental health, stress, and so on. But think about the resilience that folks have already exhibited. Having the resilience, the guts to come back time after time, that's a bright spot to me.
As they are giving these doctors, nurses, and staff members a rousing welcome to work this morning during the shift change.
Having the students have the resilience to really turn on a dime and come back and not lose confidence, not lose faith in their medical education, that's a bright spot. It's a bright spot to me to have people who develop the idea of listening to communities and adding community collaborations. It's about time, but I don't want to focus on the fact that we're long overdue in doing it. We're doing it now, and it's a bright spot for me. And it's a very much of a bright spot, and I always come back to this, I start and end with it, that learners have been so resilient at every stage of the game that they've continued to march through the sort of life cycle of medical education, and actually in greater numbers than we've had before, and anyway greater than I anticipated. Those are all bright spots for me.
It's been an incredible journey interviewing dozens of leaders across the country and to see how they are improving the lives of not only the patients in our communities, but the communities themselves, of reducing inequalities and thinking about the future and what we can do to prepare for the next pandemic.